Morning, everyone. My name is Edward Thomas. I'm a clinical social worker here at the Ann Arbor VA. My position is I'm the military sexual trauma coordinator for the Ann Arbor healthcare system and also a staff social work therapist in the PCT clinic, which stands for the PTSD clinical team.
I'm Dr. Sexton. I'm the Women Veterans Mental Health Coordinator, and Ed and I work very closely together on issues involving military sexual trauma. I also work in the PTSD clinical team.
So background on myself, I have 12 years active duty service and left active duty Army in March of 2014 when I joined the VA right out of active duty. When I was on active duty, I actually performed the same job as a behavioral health officer, doing a lot of similar things that I do today. So working with PTSD, with veterans, also had experience working in domestic violence, interpersonal violence, and also with sexual trauma background. Today's agenda, if you will, if you can go to the next slide, just looking at an overview definition of what is military sexual trauma. It's important to really understand what we're talking about because it can be very broad. And it's just a military sexual trauma is a VA-specific term, but we'll get into the details. And when we go through the prevalence, why is this important? Does this occur? A little bit of background on the military culture, what's special about this occurring when it does occur within the military, and when you think about potential effects, how might somebody be impacted by this experience, and then looking at how one begins to support a survivor, and that's very important for our conversation today. And then a little background at the end on kind of policy stuff within the VBA and the VHA side of the house, and then just looking at some overview of treatment options, really a broad overview at that point. Moving forward, I want to look at the next slide of military sexual trauma really includes any sort of sexual activity in which someone is involved against his or her will that includes, a lot of information. I did want to point out that there's a lot of information on these slides. What I want you to take from this is some of the stuff that I'll talk about. I'm not going to go over this verbatim. I know how people love PowerPoint, so I'm very cognizant of that. So we really want to hit the highlights. If someone's pressured or coerced into a situation in a sexual manner, and it's somebody that's by a supervisor, somebody's got authority over them, or if they're unable to consent to sexual activities, intoxication could be involved, or the third one, they're physically forced, into participation in some form of act, behavior, and if you look at a work environment, this could be multiple types of situations from their past experience. Threatening, unwelcome sexual advances. You've heard in the trainings that we all experience in the workplace, people walk by your workspace and they brush up against you inappropriately, and it's something that continues over and over, despite you making a comment to that individual to request that they stop doing such things. These are the types of things that we want to be kind of focusing on a little bit and taking into account when we ask and talk about this type of experience in somebody's background. When you think about compliance, does not mean consent. I want to highlight that a little bit to think about. There's times where, if I go along, I'm actually going to be safe, more safe than if I continue to struggle. And what that might look like within the military culture a few slides later, I want you to keep that in mind, So this is very important to look at a backdrop of what is military sexual trauma, or what might that look like, Next slide. Prevalence within the VA's population, we look at, these are across the VA, looking at 40%, about 48% of all veterans, that number varies, use VA services. So of that population, we look at a rate of 22% and 1%, so it's 1 in 5 females, about 1 in 100 males actually screen positive for MST. So what does that mean? That means that they screened positive during our mandatory screening sessions as they enter the VA system for some form of military sexual trauma experience in their background. It does not mean that all of these people have been raped, assaulted, or anything along those lines. It means they've screened positive for some form that met that definition. That's important to remember as well. That second bullet, how common is this within our population that we're serving within the veterans side of the house? Within here, there's a high population of males. So what does that rate look like? 54% of all VA patients screen positive for MST, looking at how many men come within our population, within our clinics, within our court systems, within anywhere that we're going to interact with veterans. There's a high likelihood that there's somebody out there that has experienced some form of military sexual trauma in their past or been witness to it somewhere in their past. So we never know who that might be. So it's important to be mindful of how we speak, how we interact with one another, because we just don't know. It's kind of one thing I always remind myself is to reset with every veteran, so I'm coming at it from their perspective. Next slide, please. Sexual trauma in the military, looking at what's unique about that. The military environment is a very small subculture within itself. You have individuals that are of a rank structure, which is likely that the individual that might be assaulted, this could be a peer or it could actually be a supervisor above that individual. Maybe in their command structure, maybe not in their command structure. It might be somebody from a totally different unit or somebody that they've never seen before but is also part of that unit structures within the military. There's a lot of unknowns. To be considered military sexual trauma, it does not have to be, the perpetrator does not have to be a member of the military. So this person that was assaulted is a member of the military and was assaulted by a civilian, that still falls in this purview. Okay? Just want to make sure that that's clear as well. Is risk typically ongoing? Absolutely. If somebody is assaulted by somebody within their chain of command, how might they interact with that individual on a day-in and day-out basis? If somebody is harassed, they might be in the same workspace, so they see that person ongoing. And what might that do to that individual? How might that individual be impacted by this? So in the later slides, we'll talk a little bit more personal in the next couple of slides about what that might look like, but keep that in mind of the workspace that this individual may be coming from during this time that this experience occurred. A lot of times you hear some people talk about, why didn't you leave? Why didn't you walk away? Within the military, how easy is it to just walk away? If you're going to report something to somebody, but this person that you would report it to is now that person who's actually harassing you or potentially assaulting you, that type of thing, what are the options that you might have available? In that, we also want to be cognizant of the age of the individuals that enter the military. These are young individuals that are coming into a system that exists on a very rank and order structured-based system. Go to this person, go to that person for assistance. But when that person is actually the one doing such acts, what are the options? Next slide, please. When you're actually considering, I want to report information on somebody else within my chain of command, how does that work with peer support, buddy-buddy, soldier-to-soldier? These are my peers that I'm supposed to go to combat with, but yet I'm being assaulted by. How might that impact an individual? Looking at the social support, if you have an individual that joins the military and is no longer around their home family, hometown, so on and so forth, they enter a new system. And some of those individuals in that area of work may or may not be supported. Disruption of career goals, if I actually report this, how is this going to impact my goal? My career goal of being in the military. I joined the military to better myself and be a part of society that actually is doing great things within the world. Okay, but now I'm assaulted by somebody that I'm supposed to work alongside and be alongside and have those same values. So there's a lot of conflict that occurs. It's something that's not in every relationship, not in every experience, not in every situation, but it's something of a potential that may occur. Next slide, please. Looking at this institution of the military, so you have military medical care, you have military treatment facilities all across the country, and even when we go downrange and overseas, those aid stations are made in the serviced by those individuals that are in uniform. Well, if this person who is in uniform assaulted me and was supposed to be my leader, what other individuals out there might actually be of that same threat? So be thinking about, did they actually report it at the time? Were they supported at the time? Are there avenues to report it? Many of you guys might be aware of restricted or unrestricted reporting in the DoD. Within the Department of Defense, they have those avenues to increase the likelihood of somebody reaching out for assistance while they're on active duty or in the reserves or National Guard. But do people reach out for that care at the time? If there are questions at the end, I can clarify what those are. I don't want to get caught up on that. But that sense of being alone and helpless, that I'm the only person that this has happened to, because they don't know that it has or may have happened to other people, and to think about that they're the only one and what that might look like to them when they're out there in their time of service.
I'm going to be talking a little bit more about how military sexual trauma tends to kind of overlap with veterans' reactions. I'm going to present a little bit more. A lot of the folks that we work with aren't specialists in military sexual trauma. They're not set up to be able to provide therapy. We'll often get asked by primary care doctors about how much do I open Pandora's box, how do I respond to a veteran who's disclosed in my office that this is part of their history in a way that's kind of appropriate and also helpful. So I'll be talking a little bit about that, as well as how we here at the VA tend to, when they do get referred to us or when they are receiving care within the VA, what are their options and how do we tend to go about thinking about that? So if you could, next slide. A few things about the backgrounds of the experience. Now, by and large, most folks who experience an MST are not going to have a significant reaction to stuff. Next slide, please. Many of them will might have a short-term reaction, but by and large, most folks will tend to seem like they're resilient. They'll seem like they get back to functioning. But for a large number of folks, they're going to have some difficulties that stay over time. And some of the things that affect that, in part, can be due to the experience. So we know that individuals that receive multiple types of whether it's repeated harassment, repeated sexualized trauma, that tends to be something that increases their risk of having difficulty in the future. Severity and military sexual trauma in all forms and all severity can be disruptive. We do, though, tend to see the more it seems to be physically assaulted, the more injury we have, that those folks are going to have a harder time following it. Single versus multiple perpetrators, this is something within the military specifically. Multiple perpetrator sexual assault is much more common than it is in the general population. There are a couple things you might see regarding the individual. So there's some different sex differences that we see here. By and large, in community samples, women are much more likely to deal with things like PTSD, depression. Men, you might see more of those external behaviors, substance use. This seems to be pretty unique, though, within a military sexual trauma population, where we see many, many more men having difficulties with PTSD, other types of anxiety, many more women having difficulty with substance use disorders as well. And there are a couple reasons that may happen. There's a lot of evidence that suggests that women in particular are more likely to have a trauma history before going into the military. Men also, the nature of their sexual assault tends to be different. They're more likely to be assaulted by multiple perpetrators. They're more likely to have a physical assault that also happens in addition to the sexual assault. There's some gender norms as well, where oftentimes you'll see male victims of military sexual trauma struggle more with concerns about, if I report this or if other people know, will they think that I'm unmasculine? Will they think that I'm gay? Will they think that I'm not manly? Which with some of the culture that's present in the military is something that folks struggle with a lot. The more trauma experience that they have is certainly going to be something that makes it more risky, that they're going to have some struggles in the future, as well as available coping strategies. So those that find ways to use humor, use social support, use other avenues of being really active after a trauma seem to do better overall. Ed mentioned a number of characteristics of the environment, so certainly the response of others at the time. There's many folks who have experienced a military sexual trauma who are told it didn't happen or who are counseled not to report it because it will be basically a career sinker. So that's going to depend on how people are, both their peers within the military chain of command. Also that repetitive need to see and work with the perpetrator over time, and many of the military culture things that Ed had mentioned regarding things like loyalty, strength, the ability to persevere. Persevere can be something that's particularly challenged by the idea of having an identity that might be associated with a victim status. Next slide. So most folks, a lot of times after trauma, whether this is combat or military sexual trauma, there tend to be with veterans things that we automatically associate, and that's something that Ed and I work really hard to educate folks about, is they tend to see military sexual trauma as synonymous with PTSD, that everyone who experiences this is going to go on to experience PTSD, and that's pretty much the only reaction that occurs. Military sexual trauma is an event. It's not a diagnosis. That said, there tend to be a couple of things that tend to go along with it. So there's a lot of information coming up on some of your slides about some of the health concerns that they'll react with. Folks that are going to struggle tend to do more so with things like PTSD-type disorders, major depressive-type disorders. There are a couple other things that show up with more prevalence than they otherwise do in populations that don't have the sexual trauma history, including substance use, other types of non-PTSD anxiety disorders, and chronic personality conditions as well. Next slide. This I don't want to spend too much time on, but there's some of the things that you may see in veterans who show up with a history. So increased rate of suicidality, self-injury. They tend to want to engage in treatment less often. The shame and anger is a big piece that we see with many of our veterans. For those of you that are working within the legal justice system, this issue with trust about authorities, oftentimes the perpetrator for their own event, or people that didn't help them report, things like that, tend to be in authority positions. And so coming from a legal standpoint, sometimes you may see more difficulties, whether that's working with their lawyer or their judges or VJOs, tends to be something that's more problematic. Boundary issues, concerns about sexual identity, more difficulty following coming home and having a stable life when they do so. So getting a job, keeping that job. Next slide. These are just some of the more common physical complaints that many veterans will express after reporting an MST. I'm not going to go over these in specific detail, but they do tend to be things that come up more often, is that you're going to have both pain and non-pain complaints higher in this population. Next slide. So what do we do about it? Everyone who's received care within the VA, those are screened at typically when they first come in by a primary care physician. Sometimes it's the case, though, that they don't feel like they can disclose it, and so many times they'll be in the system for years, and 20 years later we'll discuss it with a therapist. They can be reassessed at any time, and many do decide to disclose later. Next slide. So my guess is that most folks who are listening in on this call, you're not necessarily providing MST care, and people have some concerns about, what do I do? How do I react? If somebody comes to me or they disclose things, or this is part of their treatment notes that I'm noticing, what do I do? What's my role? And so there are a couple of slides that we hope are helpful for that. First is being attentive to privacy and nonverbal signals. Many times you'll be able to notice if they feel discomfort in certain areas, making sure that when you're asking them questions about this, that it might not be with their whole legal team there, but might be more an individual conversation that you have. These next two are the very specific. We do for a very specific reason. We don't say, have you had a sexual trauma or not? Many people don't know if these things rise to the level of what we consider a sexual trauma. So we use very specific behavioral questions. So these are the ones that the VA uses. I think they're pretty well written, come up with some good examples. So receiving uninvited or unwanted sexual attention, such as touching, cornering, pressure for sexual favors, or verbal remarks, and whether they ever use force or the threat of force to have sexual relations with you against your will. Those are the ones that I use when I'm screening people. Those are the ones that seem to work well within the VA and tend to be a good screen for people that are willing to disclose at that time. Next slide. So what do you do about it? What if you have somebody and they're in your office or you're working with them on their legal issues or things, and it comes to mind that they're discussing a sexual trauma, and you don't know exactly what to do? Do I push? Do I ask a lot of details? What's kind of the nature of my response? And these next two slides, I think, can be particularly helpful with that. So oftentimes we don't necessarily want to open up this hole if we don't sort of know how to close it back up. So even in the beginning of meeting with veterans, I don't tend to be very detailed probing with those. If you're not providing actual therapy or care or treatment, these are what I would recommend. Validation. I'm sorry that happened to you during your service. Or that wasn't okay that happened. Educating. Many of our veterans feel very alone or shameful in this, so letting them know that this is something that's actually common and that other veterans have been in similar experiences. Assessing their current status, a lot of times we think that it's a foregone conclusion that folks will continue to struggle with these. Many will not. Many will feel like, I feel like I made sense of that period in my life, or I used other ways of healing or therapy in the past, and they don't express that it's a big part of what they want to work on. Checking out the level of support. We know that the more support people have, the less likely they are to have significant struggles like depression, PTSD, substance use. So whether they've been able to talk with that about anyone, if they have some trusted people that they've talked about. And then telling them, help is available. Making a referral, especially, with people from, all different types of current clinical concerns. I never sort of press them. I'm pretty big on autonomy of, when they're going to decide to get treatment. That may be a little bit different from some of the role in legal court. That sometimes they're deciding how to do that. But I never insist, and this is particularly important within the role of a sexual trauma, when it's an interpersonal trauma where somebody has, whether it's assaulted somebody or abused somebody or made choices for somebody against their will, that we don't want to put ourselves in a similar position of being the deciders for what someone else is doing. So we always make sure that that's something that's self-initiated or a collaborative discussion. Next slide. So assessing interest, this is pretty much how I have folks when they're not in a specialty trained clinic talk with them about it. So we have specifically trained counselors who could speak to you about it. Is it something you'd be interested in it? As well as normalizing. So they don't feel necessarily so alone or so unique in what's happened. But many veterans who have had similar experiences have found it helpful to speak with a counselor. And part of that is also instilling hope that things can be better, that there is help out there for that. Next slide. This is just one of my soapbox things that I say every time I can. Trauma is not a disorder. Of the mental health conditions, PTSD is a possible outcome, and one that's more likely than others, but should not be assumed. And that what we really want to do is see what's happening with this individual. Is it something where actually the results of their MST showed up in more substance use? Or is it showing up in more clinical depression? Or is it showing up with more difficulties within the home and they're interested in something that's more couples focused? We want to work very closely with them in a very collaborative way that allows them the most autonomy that they can and also is the most likely to fit their clinical needs and help them forward in the future. Next slide. This is the model that most VAs will follow. So sometimes we get folks who come in and they're absolutely ready for trauma-focused treatment. They've been ready for years. They think they want to kind of move forward with it. However, many are not. Many are really dealing with, I was suicidal last week, or things aren't necessarily stable at home. I'm having a hard time not using too much heroin, things like that. Where really at the forefront, I can't work with somebody on opening up their trauma history unless I can be making sure they're safe first. So it's always our principal goal with people. And sometimes we might, before we do a PTSD intervention, have them do something else that's going to help them with establishing safety. Many of our other treatments involve kind of going back to the event, processing the event, understanding what's happened historically, and then reconnecting them with their present life. So with this trauma and with this history, how do they move forward? How do they still continue to have the same goals and meaning in life that are valuable to them? That's kind of the three-stage framework that we typically use for here. Next slide. There are a number of evidence-based treatments that work. So, obviously don't need to memorize these, but we have a lot here, and we've been looking a lot at the effects of sexual trauma for quite a long time. For many, those top two are going to be PTSD treatments. We have behavioral couples counseling that sometimes is used before PTSD treatment or sometimes during or instead of. Seeking safety is another intervention that's focused on both seeking safety and the DBT, on prioritizing that safety first before opening up the history. Acceptance and commitment therapy has also been studied, getting people re-engaged in their goals, their values, more often used for people with depression. So at this point, I'm going to hand things back over to Ed.
Okay, next slide, please. So hopefully with that, the intention was that to provide you a backdrop with understanding, one, where this individual might be coming from, two, how to engage that individual in just that first initial safety. That recovery could start with that first divulge of information that this happened during my past, and that might be to you. So to recognize and how you honor that with that individual really is that stepping off point of that individual's recovery. So where do we go from here? What services are out there? So looking at the VA, there's been a lot of changes. The military sexual trauma program in general has been around. It started in 1992. How many people remember the Tailhook conference, aviation conference out in Maryland area? So this is something that's relatively new in general. In that there was some incidents of assault that went on, and it was recognized by Congress that this is important. So they actually enacted this program. In 96, it was actually broadened to include men and women, initially just focused on women. Looking at the change of structure, we now offer many different treatments, as Mindy was just talking about, within the VA, within our communities. But there's even further change within the VBA side of the house. So I want to make note that the VBA, the benefit side of the house, has now actually honored this and said there's a military sexual trauma coordinator at the VBA regional office that can provide guidance to the individuals conducting evaluations for disability ratings in association with MST experiences in individuals' past. That's pretty significant change, and that's relatively new. Also, for the individuals conducting those evaluations on the benefit side of the house for the disability ratings, there's been specific training that's been developed in how they go about working and interacting with and assessing an individual who has experienced military sexual trauma in their past. So those are two major changes and shifts within our structure within the VA that have come about actually within the last year. Those are two big initiatives that have been pushed forward. On the VHA side of the house, the medical treatment, mental health treatment, those are some of the options that are available here within the Ann Arbor healthcare system. It doesn't matter. There's not a specific clinic that says, oh, this is the MST clinic or anything along those lines. It's actually what's occurring as a result of this experience, so they actually can provide informed care, whether it be depression, anxiety, substance use, or PTSD, if that is occurring. So what would that look like? And some of the same things that we just went over. Next slide, please. So the rest of this is really going to be talking about some policy and things that are available within the VA and the initiatives that are out there. So to give you a little bit of backdrop of, okay, so now I've identified it, where do I send them, what do I do, what might be coming up to this individual if I do send them to the VA, what might be some of the experiences, how would they be asked and inquired with, that type of thing, okay? Important to remember the definition, the sexual assault, the repeated harassment. If something occurred one time, that doesn't necessarily make it the same thing as military sexual trauma. So being kind of aware of that in the beginning. Threatening sexual harassment that occurred, okay, during their military service. For our National Guard and Reserve individuals, that's another recent change. It used to be active duty. If this occurred during your active duty service, you would actually meet the criteria for military sexual trauma and be eligible for free care, which I'll get to in a minute. But it's been expanded to include those National Guard and Reserve individuals that actually are on drill weekends. So that's another big change that's come about. MST is an experience, not a diagnosis, again, that was mentioned. And our overall rate, 1 in 5, 1 in 100. I think that's important that this does exist within the population that we are serving. Next slide, please. So just going to hit on and touch on military sexual trauma screening, the free MST-related health care. What does that mean? What does that look like? Coordinators at every medical center, the national support team that's out there, and education and training of staff. Well, I mean, we're kind of doing that today, so very good. Definitely hitting that one. And then outreach to veterans, what's going on that front, to really get into that idea that they're not alone and this is something that has occurred, they're not the first, and how we actually can attend to the needs and actually get them on their recovery. Next slide, please. So that screening that was discussed, it is VHA policy that all veterans are screened during that initial visit within the VA with their primary care provider. Often, people in the past, the stories that I've heard from veterans is that they contact an individual and they say, oh, you're not eligible for care, and it stops there. So when you have somebody within the court system that says they're a veteran and they may not be connected to the VA, it's important to recognize that they can actually call the eligibility office and say, I've experienced MST in my past during my military service, and they don't need to share anything more than that with that registry at eligibility. That'll pop them through the door, the gate, if you will. Because it's something that a lot of veterans that I've worked with who have not registered within the VA said, well, I was told I wasn't eligible, therefore they never pursued it further. So that's something that's important to recognize. How do they get through that screening part? And they don't need to divulge the incident, the details, as Mindy talked about earlier. It's something that's important, that you're protecting that individual but empowering them at the same time to be confident in what they're asking for and information that they're seeking. Again, that private setting by qualified providers. When they do go to the VA and they go into that session, it's not just going to be anybody is asking that question. It's the primary care provider, the licensed primary care provider, not just the admin clerk or that type of thing that's going to be asked or discussed. As we move forward and looking at experienced MST offered referral to mental health, it could be actually referred to mental health. It could be referred to primary care for physical medicine problems. Even dental care is potentially available. Next slide, please. So free MST-related health care. What does that mean? If the provider that's conducting the evaluation is an clinical impression understanding that this is tied to and associated with that experience, then it is free-related MST care. Okay? That's important. But that also includes outpatient, inpatient, and residential care. So not just on an outpatient basis or simply come in for a screening and that's the extent of it. No, we'll provide you with free care. The individual is also eligible for the medication side of things. Each one of these, whether you look at the medical side, the dental side, or the mental health care aspect of things, it is very important to recognize that the provider conducting the evaluation is going to make that connection with that individual. And that's their time to actually ask a lot of those questions. Next slide, please. So looking at, does the veteran have to have reported this incident during their time in service to qualify? No. As far as we're concerned within the VHA side of the house, if they come to us and they disclose that they experienced this during their time in service, they experienced some type of military sexual trauma, whether it be harassment, assault, what have you, that is good enough for us. We will engage them in assessment to see what is going on and what has resulted from this experience and provide them with appropriate care. So it's important to distinguish that as well. It does not have to be something that they're currently getting disability from. Does it mean that they can file disability? Yes, it does. As I alluded to during that initial slide on the VBEA side of the house, those changes are in place to actually reinforce that. They always could have done it before, but those are things that are recognized within our system that, hey, this is actually important and we need to pay attention to this. Thinking about if something occurred, Minden had mentioned if somebody hadn't disclosed this for 20 years and now they want to disclose it today. Okay, that is something that actually is very common. People deal with things in different ways and they try and keep it away or keep it down in their past. What's in the past is in the past, but then it pops up. And how do they deal with it today? Well, that's something that is very common within our older population within the VA, and that does not mean that they cannot get service. So there is no limitation on when they can get service. Even if there's an individual that entered the military today and was assaulted during basic training and never finished basic training, typically they would not be eligible for veteran services, veteran health care. But if that is something that they did experience during their time in service, despite them not being eligible for other VA programs and healthcare services, we would be able to provide them with care. Now, this is important to recognize that every medical center, medical facility within the VA has an MST coordinator within that facility, and it's important to work with that individual to make sure these one-offs, these exceptions to policy, where there's the reservist or a National Guard member that experienced something, how can we go about connecting them with services? That's the point person to actually help kind of drive through the system and make sure that they are eligible for care and get them into services, connecting them with services. Okay. Next slide, please. There is, as I mentioned, whether it be depression, whether it be PTSD, anxiety, all those different things could be resulting from this experience of MST in individuals' past. So we look at how does that actually end up being informed care for MST? How do you work with somebody with depression? We have rollouts that do depression care that are evidence-based treatments that are found to be very effective in treating depression. What does that look like? Well, you saw those, as Minden had mentioned earlier. A lot of every clinic that comes in, you're going to start with a standard assessment. What's going on with the individual and what programs do we have and initiatives do we have to target those symptoms or concerns of that individual? So everything is available to somebody who has this experience in their background. As I mentioned, every VA medical center has that knowledgeable individual that's working the system, the coordinator, to make sure that these services are available, whether it be in the mental health clinic, whether it be out in the CBOC, the community-based outpatient clinics, or whether it be within the medical side of the house. How are people in dental care actually aware of this may have occurred? The grinding of teeth in result of an anxiety condition. How might that be tied into some type of past experience of military sexual trauma? And one of the other big things is that community-based, the vet centers that are out there, various vet centers do provide services on MST-related concerns. Some of them don't. It's really important to reach out and find out what's available within each. Next slide, please. So looking at residential treatment programs, I just want to make a note that not every VA across the country has that capability within themselves, but we can network and we work within the VISNs to actually make that care available. And if somebody is not eligible for services typically, but does have an MST in the background, they would be eligible. And we would be able to coordinate that residential treatment under this free care related to MST. Okay, that's important to note. Again, there's a lot more information on these slides than I really need to talk about today. It's there for background reading and additional reference in the future. Next slide, please. It's important to recognize gender-sensitive care. As Minden had talked about earlier, some may have original concerns. Myself being an MST coordinator, it's something that has always been in the forefront of my mind, which is why Minden and I work very closely together. So from the initial consult, we actually have a question in there if there's a preference for gender provider, So they have that option. They can speak with a male, they can speak with a female. Their individual therapist can be a male, can be a female, and even down into the primary care setting. We can make those requests. We can honor those requests and make efforts to make sure that they are attended to. Within the treatment side, again, there are individual groups that can be done that are specific to gender. We do offer them various times of the year, and they actually, again, to meet the needs of our individual veterans. But these do vary across the country. Next slide, please. Calling the VA, getting in touch with the VA, reaching out to the MST coordinator. There's a lot of different resources that are available. My contact information is out all over the place. I go to a lot of different town halls, but really connecting them with our VJOs that are in the different facilities. I get phone calls almost on a weekly basis, connecting with services. Looking at the local vet centers, I do a lot of outreach to those vet centers to find out what is available. So there's just a couple, how do you get into care? What do I need to do? As I mentioned before, the eligibility office. Going into eligibility and you say, I'd like to get care, they look it up in the record, they say you're not eligible. Well, you got to prompt them with that information. And they're not going to inquire about the details of that, but it's something that is going to open that gate to put them into that primary care slot to get evaluated, or contact the MST coordinator, and we can coordinate getting them into an assessment and evaluation. Next slide, please. Just again, driving home the point that there is a point person out there. Okay. Next slide. There's a support team that's out there that actually is monitoring how many people are entering the VA that are screening positive within the VA. There's consultation teams that are out there that provide ongoing consultation to MST coordinators, consultation to individual providers that are working with individuals that have screened positive or have experienced this in their past. So there's a lot of technical and expertise that's available to individual providers. So we look at ongoing consultation and continuing. And actually furthering that is what we're doing today and reaching out to you guys. And again, what are your specific questions and concerns? We'll address those in just a moment. Next slide, please. We continue to do outreach. There's tons of stuff that I've tried to do here within our facility across the internal side, but I also work closely with a lot of the local agencies here in the Ann Arbor area and out into the CBOX in Flint, Jackson, Toledo. So it's one of those messages that I like to send of the veteran doesn't reside here at the VA, but actually resides in the community. So I do a lot of outreach and educating on what does this look like within a veteran population. They work with a lot in the civilian population of sexual assaults and stuff along those lines and harassment, but what are the important things that to consider when working with veterans? So it's something I do quite often. And there's a couple of web pages that are out there that you may have seen. Make the Connection and PTSDVA.gov. The MST is addressed in those as well, so those are good informational points.
Great. Well, thank you. Everyone have a really good Friday, and thank you again for attending.
Thank you very much.
Thanks. Take care.